Good day all, my name is Kingsley Otugo, a graduate program participant with the Queensland Mental Health. This presentation is on suicide-related issues, but before I break down the subtopics, I would like to briefly talk about suicide-related issues. Suicidal ideation and behaviors and/or deliberate self-harm are not particular to only mental health illness. However, there are higher chances any of these may occur to people with mental illness compared to the general population. Self-harm is inflicting intentional physical injury on oneself with intent of coping with an overwhelming emotion, and suicidal ideation is the preoccupation with or thought about suicide. Hence, this presentation shall cover the introduction of the chosen inpatient, the risk assessment and screening tools applicable to the chosen inpatient, the risk-reducing nursing interventions that can promote person-centered care, the non-pharmacological treatment for the chosen inpatient in this case study, and my reflection on challenges in nursing care. The chosen inpatient is a 23-year-old Caucasian male brought into hospital by his father due to non-compliance with medication following the death of his grandmother and breakup with partner, hence leading to relapse of psychotic symptoms, increased suicidal ideation, and self-harm. He had called his father and voiced that he was distressed, anxious, and feeling overwhelmed. He reported racing to All inpatients presenting with suicidal ideation must have the risk assessment completed and filed into their medical records for management purposes. For the selected inpatient, the risk screen has been used after the trial screen had identified that inpatient is at high risk of suicide. The triage is used to document the immediate needs of the inpatient and support planning for the service use. It is often used for new admissions who are not known to the service. This document captures the inpatient's referral mode, reason for referral, health-related history, including physical, mental health, and alcohol and other drugs, alerts, mental state examination, substance use, current treatment, psychosocial functioning, risks, protective factors, trial scale, and action plan. The risk screen is utilized in documenting the inpatient's protective factors and risk factors as well, summarization of how these factors interact in producing an overall assessment of risk, and help to develop and implement care plan that includes risk mitigation strategies. The document helps clinicians to determine whether a more comprehensive risk assessment should be conducted on the inpatient, including when, where, how this should be, how this should happen. Risk screen is used for an inpatient that has identified as high risk during a triage through the triage screen assessment, faced a significant change in circumstances which impact on risk, with significant change in risk, and or when a more comprehensive risk assessment is needed. These two identify static, dynamic, and future risk factors, information that are yet to be discovered. These are marked as unknown, and the protective factors that may mitigate all these risks. This document is divided into sections including static factor, which are historical factors. These factors remain unchangeable. Dynamic factors, which are current and or ongoing events, yet may be longitudinal but can be altered with interventions. Future factors, which are circumstances that are identified as possibly occurring and may impact risk, such as reoccurrence of previous triggers or stress that is related to major events associated with high stress level. And protective factors, which are available resources that can mitigate the identified risks. This may include but not limited to family support, financial stability, and supportive networks. The overall assessment and risk mitigation plan is done by understanding and articulating the relationships between all risk factors with consideration of frequency, pattern, severity, consequences, imminence, factors that increase risk, and protective factors. The chosen inpatient has answered yes to the following under suicide section of the risk screen document. For static factor, he answered yes to previous attempt of suicide, previous self-harm, and stressful life event. For the dynamic factors, he answered yes to suicidal thought, plan, and loss of hope. Therefore, this shows that his level of risk appears highly changeable due to factors like non-adherence to medication, social stresses including the loss of his grandmother, and ongoing substance misuse. In the next slide, we'll be talking about the nursing interventions. There are several nursing interventions that can be used to care for an inpatient with suicide-related issues. However, I shall be discussing the therapeutic visual observation and sensory approach interventions. The therapeutic visual observation, also known as TVO, is conducted on a 15-minute basis in this case to ensure inpatient's whereabouts and safety. It is the responsibility of all involved treating team to ensure TVO is carried out parallel with the assigned TVO clinician. This is in line with the 8th standard of the National Safety and Quality Health Service Standards, which involves effectively recognizing and responding to acute deterioration, which in this case is suicide-related issues. Research shows that mental health visual observation, when conducted in a more individualized therapeutic approach, can minimize incidents like suicide, physical violence, and sexual assault. For instance, during the 15-minute visual observation, asking the inpatient how they are feeling at that moment is more effective than just citing the inpatient and walking away, because the inpatient will feel safer with the former type of check than the latter. And this can improve inpatient recovery as well. Also, engaging with the inpatient therapeutically during a visual observation will give a better insight on on how the inpatient is feeling at the moment or at that moment. Therefore, improving inpatient safety and even therapeutic alliance, that is building therapeutic alliance with your with the inpatient. This is a shift from observing inpatient's physical integrity just passively to a trauma-informed and individualized approach. Therefore, high quality of care is achieved with a better recovery process while reducing risk in all spheres and maintaining a good patient-centered care. Next is the sensory approach. This intervention helps the inpatient to self-regulate when in manic or depressed mood. Sensory approach helps to decrease self-harming behavior, improve interpersonal skills, and the ability to manage distress. It creates a safe environment in which to engage in meaningful activities and aids the reduction of restrictive practices. Inpatients mostly utilize the chosen inpatient mostly utilize the courtyard to play basketball with nursing staff and listen to music when depressed in mood. Inpatients also watch TV, access sleep with family, play card games to self-regulate. This is also a good strategy for inpatients when discharged back into the community. In this slide, we shall be discussing two non-pharmacological treatments that can be used for the chosen inpatient. First is the electroconvulsive therapy, also known as ECT. Electroconvulsive therapy is a worldwide known treatment, and the method has improved over the years to achieve a better result and a much reduced side effect. ECT is a safe and better treatment option for severe depression, and this is not given to anybody that is deemed unfit for it, as a physical health like the cardiac condition is part of the pre-treatment administration assessment. ECT is very safe because it is a regulated treatment under the Mental Health Act 2016 and administered under certain circumstances like informed consent of an adult person who has been deemed fit by a psychiatrist to have informed consent capacity under the Mental Health Act 2016. Approval of the Mental Health Review Tribunal, that's the MHRT, for an adult that is unable to provide informed consent. With approval for with approval of the MHRT for minors, or for the emergent situation circumstances for certain involuntary patients, for instance, inpatients under treatment authorities, forensic order, or treatment support order. For ECT care expectation, the number of ECT treatment differ amongst inpatients and require ongoing review by the treating team. However, a maximum number of treatment course for an individual is 12 in Queensland, with exclusion of the involuntary inpatients where MHRT can approve an ECT treatment course above 12. In a situation where the treating consultant determines a good clinical response and mental state stabilization, ECT is ceased. The second treatment we'll be looking at, or the second treatment I'll be talking about, is the cognitive behavioral therapy, also known as the CBT. This evidence psychotherapy is a collaborative and individualized program which aids inpatients to identify unhelpful behaviors and thoughts and relearn or learn healthier skills and habits. When exposed to stress, some inpatients can find problem solving difficult and can resort to self-harm or suicidal ideation, as in the case of the chosen inpatient. Therefore, this therapy has been used to treat a variety of mental conditions, including depression, anxiety, generalized anxiety, post-traumatic stress disorder, also known as PTSD, panic, childhood anxiety and depression, eating disorder, and anger and stress management. CBT can be administered as a one-to-one therapy, although also often as a group program. Therefore, it can be a one-on-one or it can be a one-on-one therapy or can be administered to a group of people or one that's called one to many. There's one therapy to many inpatients. The success of this therapy relies mostly on the development of collaborative therapeutic alliance with an individual or group of individuals. As for the program, next we shall be looking at the challenges in nursing care, which is going to be my reflection on what I have the challenges or the the experience that I've witnessed working in the mental health world, the acute mental health world. In this slide, we'll be discussing the challenges in nursing care. I'll be talking about a reflection on the experience I've had in the acute mental health world. But before that, I would like to talk about reflective practice. Reflective practice aids nurses to follow a structured cycle to revisit their past clinical experience and learn from them. This process enhances learning and helps nurses to cope with mental and emotional challenges in a clinical setting. It can be used as a self-appraisal tool or an evaluation tool for clinical improvement. So with the use of the Gibbs reflective cycle, I shall talk about the nursing challenges I have witnessed around safety in the workplace. Although this is not a challenge, this challenge is not about the is not with the chosen inpatient in this case study, as he was compliant with all the nursing care during the period. But I'll reflect on the experience I witnessed around another inpatient uh, led to irritability, aggression, and a near miss assault. Without wasting much time, I would just go into it. Um, it was around 1100 hours, that's 11 a.m., when a new admission under the Mental Health Act Treatment Authority he was elevated, loud and verbally threatening on the ward. This was unsafe for other inpatients on that ward as other inpatients voiced their fear to the nursing staff. Reassurance was given, and these inpatients were removed from that space at the time. Counseling and redirection were offered to the elevated inpatient with no effect. PRN was offered, to which inpatient accepted some and declined others. And for PRN, which is also known as the pro-renata or as required medication, is when the medication is or are prescribed and administered based on urgent inpatient need instead of the regular time scheduled medications. The only option that was left was to transfer the inpatient to a high dependency unit where he could be monitored more closely on 15-minute lead therapeutic visual observation for safety. And this was also to help him calm down. And the psych registrar authorized the ward transfer at this time. The inpatient became more resistant to the transfer and even more elevated. Hence, we had to call the security to assist with the process of transfer. This led to the inpatient pulling out his scissors and threatening the security with this. After a while, this weapon was collected from the inpatient and transfer was completed successfully. I'll talk about my feeling. In that moment, I felt confident working in a team to de-escalate the situation, although On the other hand, I felt the environment was unsafe for both the team and other inpatients in the ward. If my evaluation about the experience is that the situation was scary and this can be traumatizing to most people, including the clinicians. However, the clinicians involved exhibited a good and quality clinical governance in the situation, therefore minimizing risk and increasing patient safety. Also, the clinicians and security personnel involved displayed courage, which is one of the core values of the Darling Downs Health. In analyzing the situation, there are many other ways it could have ended up badly for both the staff members, the escalated inpatient, and or other inpatients on the ward. However, teamwork amongst the staff members and therapeutic alliance with other inpatients had removed this risk or minimized this risk greatly. Therapeutic alliance is the collaborative relationship between an inpatient and clinicians that leads to the development of a working bond during the process of recovery and an agreement on treatment related goals and tasks. Therapeutic alliance can really go a long way, even though it is not directly with the agitated inpatient, but gaining other inpatients' trust to keep them settled and away from this risk while trying to de-escalate the agitated patient. Therefore, therapeutic alliance is really good in this type of situation. Uh, So in conclusion, the nursing team had exhausted every other intervention available to de-escalate the agitated inpatient before involving the security and transferring the inpatient to a more secure and quiet area to calm down. And these interventions included the counseling, the redirection, and the PRN medication, as mentioned earlier. What is the action plan here? The action plan is for nurses to keep up with their professional development, and this helps a lot in this sort of situation as every intervention is instant and must be practiced and must be of best practice. I mean, and in addition, clinical trainings like occupational violence prevention (OVP) are very necessary in such situations. So I encourage nursing staff to just keep up with their continuous professional development, and keep stay up to date with every information to always exhibit uh, that that best practice on the wall. Thank you for listening. Thank you.